Now for the rest of the story for depression part 2. So, got finished with that last video and said, oh my, we didn't talk to Scott about how to change his medication. He had to get going on the phone, so we didn't get to talk to him about how he's going to actually make the change. And that's really important that we talk to him and give him some instructions. So I'm going to go ahead and give him a call while we're right here, and we'll talk him through the transition. Okay, waiting. Oh, hello, Scott. Yeah, how's it going today? Have a few minutes to talk? Wanted to go over that medication change with you so that you understand how to gradually increase the new medicine and stop your old medicine, okay? Yes, yeah, I'm sure you did have the questions about that. Okay, all right. And you are continuing the sertraline every day right now. You took a dose this morning, all right, because you weren't sure. That's fine. Oh, you want to have Sue talk to me, your girlfriend? Okay, all right, put her on. Hello, Sue. All right, so here we go. We're going to talk about how to change over his medication. I've called in a new prescription down to the Hannaford where it is inexpensive. He's going to gradually go off the sertraline while gradually adding the new medicine in. So it goes like this. Today is Monday. I want him to take a dose of sertraline on Wednesday and Friday, but not on Tuesday and Thursday, and then he'll be done on Friday, and then you should discard those pills. And then the bupropion, he gets started on Tuesday. He's going to take just one pill for now in the morning on Tuesday and on Thursday. And then starting Saturday, he'll take one pill just in the morning on the bupropion for over the weekend until Monday. And then on Tuesday, he can start taking twice a day, the bupropion 100 milligrams extended release. He'll take it twice daily, once in the morning, once in the evening. I know it's harder to remember a medicine twice a day. Do you think you can help him with some strategies? Oh, a pill box, good idea. Okay, great. And if you can do that, and just make sure he takes that in the evening time as well as his morning dose. Okay, great. All right, does all of that make sense? Good. Okay. Yes, of course, all these medicines have some side effects, possible. And remember the conversation he probably told you about when we first started the sertraline. All of these medicines that help with depression, in some rare cases, can cause people to have some more severe depression symptoms or become very hyperactive. And so if anything very odd starts to happen, he should go straight to the emergency room and get checked out. It's also very rare as well, but sometimes we see people get a very high blood pressure and a high temperature if they get too much of these medicines, especially if they take like some over-the-counter herbal medicines like St. John's wort, which you don't want to mix up with this. So sometimes things can interact, so we have to be really careful on that. Right. Okay. So, right. So those are the severe things. Common things are pretty much like the sertraline, except there's a very, very small number of people who have trouble with the sexual side effects on bupropion. So that's a good thing. Yeah. And but the stomach thing can bother some people. So again, if he wants to take it with some food, that's fine. Sometimes that'll help if he seems to be bothered. Yeah, most people tolerate this very well. And yeah, it'll help his smoking. It'll help him quit smoking. Great. All right. Yeah, you quit too. Good. So the two of you can work on that. All right. So I do want to just chat with him in 1 or 2 weeks to talk about side effects, if he's having anything that's going to make him try to stop the medicine, or if anything new and different has happened. And then in 3 or 4 weeks, we'll get together. Yes, there's an appointment right in the book for looking at to see how this medicine is controlling his actual depression symptoms and how that's going. Yeah, if he wants you to come along, you're more than welcome to come to that visit. Your input would be really valuable, I'm sure. Yeah. Okay, well, thank you very much, Sue. I appreciate your time. And keep in touch if anything new or alarming occurs, okay? Thanks. Bye-bye. So just to summarize, I think I kind of walked you through in terms of the little vignette with Scott's girlfriend. We're going to really be focusing on what they call a simultaneous taper off and titrate up. And that's just because these drugs are in different classes. The sertraline SSRI and the bupropion is in that miscellaneous class. And so honestly, I also have seen it, especially on these lower doses, that it's fine if you just stop the sertraline and start the bupropion. But I wanted to kind of walk you through what we're talking about with cross taper. And of course, with things like MAO inhibitors, you're going to be so cautious about there's no overlap. You're not allowed to overlap at all with those drugs. They have to be stopped. You have to wait 2 weeks at least before you start any other antidepressant medication because that can be dangerous. So I would be careful. And also, if you're on a higher dose of fluoxetine, that half-life is so long, sometimes we just stop the drug, wait a few days, and then start the new drug, and kind of to avoid overlapping and causing a serotonin syndrome thing to occur. Again, that high fever, rapid pulse rate, high blood pressure, etc., which are all the signs of serotonin syndrome. And there are some others as well, but that should be on your worry list when you think about something new happening with your patient. Now, Scott's young and healthy, we presume, and so we're not going to really have much in the way of other monitoring for him, except looking to see if he's having a good effect of the drug and without too many side effects to make him stop the drug. But again, if he was elder, we would be watching him, particularly for renal function. Most of these drugs, we do have to be careful about that. So, to summarize, prescription tips for antidepressants: start low, go slowly. Incorrect grammar there. Most meds take at least 2 weeks to have a full effect, although initially you may see some energizing effects early on. And I have seen this quite a bit. And it isn't that they're going into a mania or a hypomania. And yes, we are cautious about that. And if we do see true mania symptoms, we want to discontinue the medication and get them to care and get evaluated. But in terms of general public, a fair number of people get a little kind of just feeling better, kind of like, wow, for early on. And that tends to settle down a little bit. And then later, again, their symptom management is what we're after. Most medications really should be tapered if we're planning to discontinue, because again, there is a discontinuation side effect. It doesn't feel good, and it's not that they're addicted or anything like that, but they do get kind of a flu-like syndrome and feel kind of lousy. So here's a bunch of patients who I want you to think about, and I will post some suggested ideas for choices of medication. It's not a homework assignment. Just want you to think about it and consider these thoughts as you prepare, yourself for thinking about your quiz and so forth. So think about, then sticking within the SSRIs for the most part, and SNRIs, which drug might be the best fit. Elder patients, thinking about things like drug interactions, thinking about which, of course, most of these drugs are actually metabolized with the cytochrome P450 system, so that makes it a little difficult. Elder patients as well, we're going to be careful not to have something with a real long half-life going on. On the other hand, our young patient who forgets to take medication, we already mentioned that a long half-life might not be a bad idea. Those with cardiac histories, you know, again, we want to be careful. There are many of these drugs have a tendency to be on the list for the QT prolongation. So if they already have a prolonged QT interval on their EKG, and we would know that because they are cardiac patients, we're certainly going to avoid any of the drugs in these classes that might push that QT interval longer. Also, you know, also of course, although not in the SSRI category, but the tricyclic antidepressants are really tough on the cardiac as well. Suicidal ideation, every one of the SSRIs, SNRIs has a black box warning about suicidality. This is more applicable in younger patients. However, we're careful about it with all. There is some thought that this may be due to kind of the lifting of the depression, and thus the person kind of saying, oh, yeah, I don't feel so depressed now, I can actually go through with plans to kill myself. But we don't really know why this happens, and it isn't very many patients, it's very few. But it's certainly if they do have suicidal ideation, we're careful about titrating them up slowly, watching them very carefully. And of course, again, the tricyclics are you know, lethal in small quantities, so I just don't prescribe those to that population. Polypharmacy, that goes without saying. People, you want to stay away from drugs that have a lot of CYP450 interactions. Targeting symptoms. A person has more vegetative symptoms, so you would want to go with a more stimulating drug, right? On the opposite end of the spectrum, people who are anxious or excitable, stick with the drugs that might be more sedating. And in fact, like paroxetine, Paxil, has actually an indication for anxiety, and it is also great. I usually have people take it at bedtime because it is sedating. The tobacco issue we already talked about in terms of bupropion being a nice 2 minutes in one drug. Okay, so I'll see you in the next video talking about anxiety.